Jordan at this hospital, Lexington. We're doing our what will be weekly updates on COVID-19. Dr. Rodrigue will be talking in a few minutes. We had wanted to have Dr. John Barton here for an OB update, but he wasn't able to come today, so hopefully we'll have him next week. His national guidelines are going to be published pretty soon for OB care in COVID-19. As you can see from looking at me, I have one of the few things we're going to talk about today is the importance of face shields. So I'm going to hand it over to Dr. Rodrigue now.
All right, today we are well into our second month of working on preparation for COVID. And at this point, I know people are getting a little bit tired and fatigued in some areas. Just remember to be thankful for what we all have. We are going through some difficult times. There are issues that aren't always clear, but we're all trying to make things better. So in treating each other, treat each other kindly. Watch some of the meetings I've been in sometimes get a little bit contentious, and that's pretty normal for the amount of increased stress that we're having trying to cope with this new illness and this outbreak. So with that being said, we're going to review the latest epidemiology and some changes, our newest clinical aspects of COVID and treatment, and then again, some of the changes in infection control measures. Previous talks have touched on the epidemiology, so I'm not going to linger on some of this. The slide decks are going to be available online, so no need to some of these older slides. But story, you know that this outbreak was reported initially in Wuhan, China, and sequenced as a new virus called SARS-CoV-2 because, again, it has a similarity to the previous SARS outbreak. The illness that was reported initially began around Christmas, and then, as you can see, there's an outbreak curve that increased up to the point of being declared a health emergency by WHO, and then a pandemic on 3/11 in 2000 this year. The outbreak map now. This is from the WHO site. In terms of new cases, you can see that the United States at this point has a darker color, and China does not. So there is a difference in terms of where this outbreak has increased. Some people are focusing on potentially the lack of information from China. I think that's really not something to focus on at this point. We have our own epidemiology. We know that it likely began in China, and at this point, we are seeing increasing cases in the United States and in other parts of the world. Global cases will always be increasing. This is from last night at midnight. If you check the WHO site now, it's already 901,000 cases, and I'm sure it'll be over 1 million cases the next day. Instead of 45,000 deaths today, as an hour ago, it's 50,000 deaths. So this will increase. This will increase over time. You have 107,000 in the Western Pacific area, over 3,000 deaths, and in Europe, over 500,000 cases with 33,000 deaths. The case fatality rate has still been reported around 2%. That hasn't changed much, with the highest risk factors being age and comorbidities. In some ways, this is an outbreak that is also intersected with outbreaks that we really haven't thought about, especially in the United States. And that means the increase in our chronic illnesses like COPD, diabetes, et cetera. Those now have played a role in terms of patients getting this illness and then becoming more ill. The incubation period is 5 days. You will read incubation periods differing between different outbreaks and groups of patients. Like the incubation period, coronavirus outbreaks in the past in terms of SARS and MERS, this is probably a bat origin by genetic sequence with an intermediate species. and the pangolin, which is is scaled anteater on the right part in your slide, is thought to be the potential intermediate host. Transmission is still thought to be droplet contact and aerosol. And there's still at this point no great evidence, no good evidence really for vertical transmission in pregnancy. You are going to see some articles, one that was published on the last talk 5 minutes before the talk that mentioned potential IgM antibodies found in infants. That data is still somewhat flawed. The majority of data looking at vertical transmission does not show any significant evidence. You're going to see different articles talking about of this virus in different specimens. And again, when you read the literature, it is a little bit confusing. There are some series that report higher percentage isolation from different specimens than others. And I find that a little difficult to look at. Oftentimes, the quantity of specimens obtained to give you that percentage is small. So today's talk, I would still think that nasopharyngeal is the one that we tend to look at in terms of believing that specimen, oropharyngeal less so. And we know you can isolate it in stool, although the significance is not as clear. And in sputum in one study, although as mentioned previously, the majority of patients don't really produce much sputum. You can isolate it from urine. It's uncommon from small studies. Also, blood in the past has been associated with disease severity. So if you're incredibly ill, you potentially can isolate that from blood. SARS found on surfaces, risk. This is also, fomites are important. So if you go into patients' rooms, you'll find it on door handles, you'll find it on cell phones. It can persist on surfaces. If you look at other coronaviruses up to 9 days, there was a study done looking at its persistence on different types of items, whether it's copper, metal, cardboard, and then if you use a machine and create an aerosol in a lab, how often could you detect it? That, in general, giving you some guidelines. Cardboard lasted 24 hours. When they aerosolized it, potentially could last for 3 hours in the air. But this is not an inconquerable virus. It is controllable with controllable soap and water, which affects the virus membrane and can kill it, but also ethanol solutions and dilute bleach solutions. If you go to websites again like cdc.gov or who.int, there are recommendations for how to disinfect. Here's a evolving aspect of this illness that wasn't appreciated, and this is uncommon. As you have a new virus, you're going to find out characteristics of that virus as more and more information comes out. And who knows? There's probably over 6,000 articles written, and the majority of them not peer-reviewed yet or not published yet. Initial story from China did indicate that there were some asymptomatic transmission. But as you continue to mature in terms of our data collection, asymptomatic transmission and asymptomatic patients may be playing a larger role. That is something that will be clarified over time as we collect information based on serosurveys and as we start to piece together some of these stories. So I've listed some of these in terms of sequence when we're starting to learn about it. From Wuhan, we did have some reports of asymptomatic patients passing illness on to family members. From Japan, in terms of studying a number of evacuees from China, they estimated that 30% of the COVID cases that they detected on those evacuees were asymptomatic. When you looked at infants, a infant, a 6-month-old infant, infected her parents and had a high viral load, only had one brief, less than an hour fever, and then that normalized and continued to have high viral loads and significant in terms of transmitting it to parents. 3 employees from the Biogen outbreak out of in the United States attended the conference in Boston, tested positive, but again, did not have symptoms. Here's stories of asymptomatic transmission to a German businessman, where the index patient at the top line flew back to China at the time of attending this business meeting, did not have any symptoms, infected patient one who had contact, who went on to have symptoms later on. And then as you track it down, all these other people started to have symptoms. But during that initial index patient stay, had no symptoms. So asymptomatic transmission, again, was part of that story. Significantly, if you looked at Singapore looked at all their cases that were diagnosed, 243 cases at the beginning of their outbreak between January and March, and found 7 clusters when they went back to do some case containment. They found 7 clusters of cases reported in the MMWR where, again, pre-symptomatic transmission occurred. If you look at the virology of this virus, it starts to make some sense. 18 patients evaluated in Wuhan, 1 who did not have any symptoms, and 2 family clusters were looked at, and they looked at the virology. And of note, if you look at the beginning of that slide, beginning of that graph, patients that were minimally symptomatic or very early in their course had very high viral loads, including the patient that was asymptomatic. So the possibility for transmission could also be supported by the virology. It is also 19 has also been described as potentially as an occupational outbreak. If you looked at patients that got sick and broke it down by occupation, it mirrors some of the first cases that were also reported in our own state of Kentucky. Occupations that were associated with developing disease included those working at retail stores, domestic workers, tour guides, jewelry store workers, business workers, taxi drivers, Uber workers, security officers, as well as healthcare workers. So your contact with potentially pre-symptomatic or very low symptom patients could have led to illness, which could have led to further transmission. So this whole story is yet to be further clarified, but I think as we get more data, we'll learn more about that. Super spreading are still important. New Orleans is a good example of the social distancing measures were not put in place. Mardi Gras occurred, and then they have had an explosion of cases, which has overwhelmed their healthcare system. And the other story, which is interesting, is Singapore was held up as a model of perfect control. I mean, at one point during the description of the outbreak, they had about 100 cases. Everybody was saying, oh, this is great. But within one month, they have 1,000 cases. And part of that story was you still got to maintain vigilance. If you don't have everybody we don't have a vaccine at this point. We don't have a way to ascertain that you've gone through this in terms of doing surveys, and you relax some of your social distancing, you could potentially still have a flare of this and affecting your healthcare system. So they had to redouble their efforts in terms of control in Singapore. It still holds about 1 person with COVID probably infects 2 to 3 people. Again, another mention to remember the story in China itself, these super spreading events were important. This occurred during the Spring Festival. Most important, one of the holidays, you had millions of people going to one area, which created an opportunity for vast spreading of this virus. And before you clamp down on the city, you already had 5 million people leaving that city, spreading it to different parts of China. I think this is a great example that still supports the way we dealt with, say, the NCAA basketball tournament, or how the Democrats are postponing the Democratic convention. It's still trying to avoid super spreading events where people will congregate, potentially spread it, and then explode it again. Healthcare workers is also an evolving story. Initially, the report was through Wuhan that 3.5% or 3.8% of healthcare workers were involved in their outbreak. Not a small number, 1,700 healthcare workers. And this initial story was the majority of these healthcare workers were in Wuhan, where we could imagine a scenario where you do not have enough PPE. Things were really chaotic. They really did not, and they reported on this, they did not institute strict infection control measures. So there was a little bit of chaos. And they reported when you looked at other areas of the country as the infection spread across the country, the percentage involved decreased. However, that's not entirely the story. I think we're starting to get a little bit of clarity that gets filled in over time, and that's what's happens with outbreaks. We know that again, in some outbreaks in Wuhan, up to 30% of cases were healthcare workers. 20% in Italy were associated, and they reported it as an association with a breakdown in PPE. Spain reports 14% of their workers infected, but then the story starts to change. We don't have great numbers when it comes to reporting of healthcare workers right now. We have the New York Times, we have our own health department giving us some data, but that data is not widely reported. And there are many reasons for that. I'm not privy to all of them, but at least we have glimpses. In Ohio, 18% of their cases were healthcare workers. And in some medical systems, with all our different contacts across the country, we know that a significant percentage of new cases are involving healthcare workers. This doesn't seem to be completely out of the realm of possibility, but there are many factors involved. So it's not all about the new cases being all healthcare workers. There might be some confounding factors. In other words, healthcare workers might be tested more frequently and have access to more testing. But I think the other issue is that oftentimes we're probably getting exposed and exposing each other because we don't have a significant amount of symptoms. And I can point to data when you look at the nursing home outbreak in Kirkland, that everybody was getting infected. Healthcare workers that tended to be younger, their age was 44, were probably less symptomatic than their residents who were in the, a lot older. Their median age was 80. And between the healthcare workers getting sick, the residents getting sick, and visitors coming in and getting sick, it becomes a very difficult outbreak to control. Now, most of those residents end up going to hospitals, and a high percentage of them died. But the healthcare workers, especially in nursing homes, are still potentially focuses for infecting themselves and infecting other patients. The US epidemiology, this is as of last night, already has changed, I'm sure, but we have the case counts continue to go up, 200 some odd thousand cases, 4,000 deaths, widely distributed amongst all the states, and a state of emergency called in the United States on the 13th of March. The first death in the US was from the state of Washington in that nursing home outbreak. The states that seem to have their wildfires right now are New York, New Jersey, California, Michigan, Massachusetts, Florida, Illinois, Louisiana, and Washington. Of note, this is not a simultaneous outbreak. So in other words, every state has their different thresholds for instituting stay-in orders or social distancing orders. And that will affect the curves in terms of outbreaks in each particular state. So can you relax? The answer is probably no. Wherever you're at, you have an opportunity to have a wildfire, and you got to stay on top of it. As time goes on, and as we have more capability in terms of rapid testing, there will be easier, and then the development of therapeutics and vaccines will have an easier way to manage these small wildfires. But for now, it's all hands on deck, especially in these states where they're reporting difficulties with delivery of care. The outbreak continues to increase, which is not a surprise. The original case was back there in January, but here we are going into April, and the cases continue to increase. As you look at this map, the areas are getting darker over time, which is not a surprise, but you can see that it's not a simultaneous outbreak. You look at the middle part of the country, it's not as dark, and hopefully that continues to be so. But that again requires the ongoing vigilance in terms of our dealing with whatever those risk factors are to increase our cases. This hasn't changed. This is our initial report in the United States, breaking down by age group where you ended up, and significantly showing that even though you're in the younger age group in terms of 20-year-old, you're still significantly sick enough to get hospitalized. So the message we have mentioned before oftentimes gets lost, that if you're, you only have to worry about this if you're old, if you're over 80. But really the answer is no. You can be a 20-some odd year old and still end up in the hospital, because this virus does make you ill. Your chances for death are lower, and your chances for getting intubated are lower. But we have all heard of cases where you're younger and you still get significantly ill, end up in the ICU and potentially on a ventilator if you've got comorbidities like asthma. This map of Kentucky is still getting filled up. Our first case was reported on the 6th of March. Currently, as of yesterday, we had 680 cases. This will continue to go up. Almost 8,000 people tested and 20 deaths. And we declared a state of emergency as a state on the 6th and instituted good measures in terms of trying to improve social distancing, canceling events. And to date, the modeling for where this outbreak will go in Kentucky still is pointing toward May as a time when we'll experience more of a surge. There are a lot of factors involved with these modeling, and it really depends on what parameters you put in there. But I still think it's reasonable to think that May is what we're looking at. How does this compare to other pandemics and other epidemics? Well, the swine flu we report in 2009 was probably the last biggest epidemic that people can potentially remember. We didn't have a lot of deaths because the case fatality rate of this organism was a lot less, but we did have significant number of cases, over 60 million cases and 275,000 hospitalizations. And it did stress our system to a certain degree. I remember many cases in the ICU. I mean, it did take up a lot of beds. The Spanish flu was the one that people talk about, infecting over 500 million people, one third of the world's population. And if you look specifically at Kentucky, going backwards, probably killed an estimated 15,000 people in Kentucky. And in Lexington alone, about 1,000 people. And eerily, you had similar proclamations in terms of trying to deal with this outbreak at the time. Remember, we didn't have Tamiflu. We didn't have a vaccine at that time. We just had social distancing as a way to deal with it. And so if you look at the orders that were involved, we did on October 7th, 1918, we closed schools, churches, weddings, funerals, colleges and universities. And when you looked at the wards at St. Joseph's Hospital, which was on 2nd Street at the time, and Good Samaritan Hospital, they were full of flu patients. Now, the ease of transmission is related to its reproductive number, the R naught. And now R naught is a function of three main parameters. Includes the duration of contagiousness. How contagious are you after you get ill? The likelihood of infection per contact between a susceptible person and an infectious person, and that probably represents how virulent is that organism. And then the contact rate. So if you're infected, but you live on on top of a mountaintop and you don't see anybody, the likelihood is you're not going to spread it to anybody. When you look at that, SARS-CoV-2 is more infectious than the flu, was more infectious than Ebola, but less infectious than measles. And remember, we control measles because we have a vaccination. And otherwise, if you had a completely susceptible group of patients, it's very contagious. And having worked on different measles outbreaks in the past, I can tell you in a susceptible population, it spreads very easily. Clinically, what are we learning? Still, it's not easy to distinguish this illness from a typical viral illness. Most people have a fever, cough, dyspnea, myalgias, extreme fatigue, sputum production, headaches. So a lot of these are typical symptoms. And when you go back into the literature, again, it really depends on which outbreak and which group of patients you're looking at, because Singapore reports a slightly different, milder set of patients than Wuhan reports. But overall, this still holds true. Shock in a certain percentage of patients, arrhythmias because of potentially myocarditis, loss of taste and smell can be a presenting sign, as we discussed last week. Most people kind of have a phase of illness. In other words, the first week, it's about a 2-week illness. The first week, you tend to have more viral-like presentation. You might not have that cough. You just might be fatigued, have a mild sore throat, muscle aches. But then over that week's period, you get potentially more ill, a little bit short of breath, and end up being hospitalized. Some patients can get admitted and then develop the fever afterwards. You progress to ARDS in a smaller percentage of patients, 3.4% in the Wuhan outbreak, usually within a week and a half or so. And if you do progress to ARDS, your mortality really does go high. This also affects the kidneys, 7%, the heart in terms of a myocarditis, an acute cardiac injury, maybe 12%. ICU admissions depends on which document you read. 5 to 30% is probably more along the lines of 10 to 14% to 15%. And secondary infections depends on which publication you read. But the important point is it's not an overwhelming presentation. So secondary infections oftentimes with viral illnesses will occur after a week or two of being in the hospital, and it may be related to other things, such as, nosocomial issues. You got lines in place, Foley's in place, et cetera. So on the whole, while antibiotics are oftentimes used, especially for the more critically ill patients, this tends to not be a bacterial illness. It may occur 5 to 10% of the time, but don't continue those antibiotics the whole time, because potentially you could make them have complications. The more experience we have and the more we look at serosurveys, et cetera, I think we'll get an idea of most cases being less severe, but that tends to take some time. Cytokine storm is still a major issue in a smaller percentage of patients with multi-organ failure, but we'll touch on that a little later. So using that information, we know that patients that are at higher risk with comorbidities and age, especially if you're over 80 years old, you will more likely have a more serious illness, and we need to have more vigilance for those patients in terms of progression. The first patient from Washington that was reported in the United States, this is the first case reported in the US, kind of is typical. I still have this slide in there. It's about a 2-week illness. The cough is about 2 weeks. The fevers tend to be lower to start with and then increase over the first week and then peter down. And it has a number of symptoms we discussed: fatigue, nausea, vomiting. The GI symptoms are becoming stressed more in some of the later literature as people focus on the spectrum of illness. So a GI illness with some loose stools, maybe not frank explosive diarrhea, have been reported. Chest x-rays initially can look okay, can look normal, and then over time, within the first week or so, you will see some infiltrates. To give you an idea of some of the cases in Kentucky, I've just had a real brief snapshots, and the purpose of this is to tell you, not everybody's coming in with the diagnosis of COVID. Our first case that we saw presented as an acute stroke and had a viral illness, oh, by the way, and really was fortunately recognized as a potential COVID case. But these other cases are interesting. Okay, so a 29-year-old presents with a sore throat and a peritonsillar abscess, had an exposure history by further questioning. So had a bacterial infection, but actually had COVID at the same time. So unless we pay attention, we're going to get burned on a patient like that, especially since she was probably had a significant viral load, and we're getting ready to take her to surgery to drain a peritonsillar abscess. So you really got to pay attention to that patient. Patient comes in with just she had allergy symptoms, and then only later developed some fever. This is the allergy season with spring and summer coming on. So again, that has to be in the back of your head. Nursing home resident with a non-productive cough, that's more typical, and then developing shortness of breath. And then one of the last patients that we saw, 69-year-old with diabetes and hypertension, who really that first week did not have a cough, but just extreme fatigue, could not get out of bed, and then went to her primary care. and then test positive, was admitted, and again into the second week worsened and is intubated in ARDS. And that occurred really within days. You can look relatively well and then decompensate fairly quickly. There's a X-ray and CT scan looking at the ground glass infiltrates. I don't know if I can get this. But here's the ground glass infiltrate, which is thought to be fairly characteristic for COVID-19. So the labs aren't specific, but if you were trying to do broad strokes of what to look for, typically a patient will have normal white cell count, oftentimes with lymphopenia, 40% in one study. And there are some labs that are associated with increased severity and mortality. You will look at different papers, they will say slightly different things. For example, they will say lymphopenia absolute less than 0.8. Another paper mentions 0.6. It kind of depends on how you have your cutoffs and looking at the data that's in front of you. CRPs over 100, leukocytosis and how it's elevated absolute neutrophil count to lymphocyte count. So if it's greater than 20, potentially those patients are headed for ARDS. As it's around 2 or less, potentially doing better. Elevated ferritin levels, 300 to 500. But again, oftentimes if they're really ill, their ferritin levels are in the thousands. Elevated creatinine, elevated procalcitonin, elevated LDH of 245 in one study, D-dimer, IL-6, one paper mentioned greater than 11 picograms per ml. But again, we send off our IL-6 levels. We don't get them back in real time to help us stratify. Also elevated ALT with hepatitis and SOFA scores, which that's a sequential organ failure score, which we'll pay a little more attention to as time goes on. You can shed this virus for a while, longer in non-survivors, but although it's not always clear, looking at PCR data on viral loads, whether that patient is truly infectious. In other words, we'll do PCR swabs, but is that evidence of just the virus being present, or is that truly going to be enough to transmit the infection? That data isn't that clear. For most patients, this is still a 2-week illness. If you're in the low risk category, but longer, up to 6 weeks or longer for severe disease. You can still have a cough that persists for weeks, which is not uncommon with other viral illnesses, a fever that persists for weeks. And if you look at one study, any symptom can persist for up to 24 days. If you're mechanically ventilated, this is not typical. We look at mechanically ventilated patients with a lot of experience with bacterial infections and even influenza. Oftentimes we have a natural history expectation of those illnesses, and we're learning more about this illness. So most people, when they're mechanically ventilated, they're not going to get off in a couple of days. They're generally going to be getting off in weeks, not days. And that partly is dependent on their physiology. It's quite damaging to the lungs if you get to that point. It doesn't resolve very easily. ARDS is the leading cause of death, but there are other causes, including myocarditis, cytokine storm, where you have multi-organ failure. If you look at cytokine storm, it's a secondary process, basically a dysregulated immune response to this infection with end organ disease. And this is not uncommon in some other illnesses. Oftentimes we have patients that have infections, and then for example, in HIV, they can have an infection. We reestablish their immune system. They start to have a hyperimmune response to their infection, which causes a secondary organ injury. For these patients, typically, I'm just giving you a brief skeleton, but it's looking at O2 saturation, respiratory rate. So as that respiratory rate starts to climb, especially over 2022, you have to start worrying about clinical progression and vital signs and typical labs to follow. I listed them down here. It really will depend on your institution. There isn't a perfect system. Some institutions will ask for different monitoring, but basically looking at the CBC, complete metabolic panel, CPK, CRP, SED rate, ferritin, procalcitonin, D-dimers, LDH if elevated, follow it, troponins, looking for the myocarditis, EKGs, because again, you're looking for evidence of myocarditis, and also QT interval if you're using agents such as hydroxychloroquine, which can increase your QT interval. It's probably reasonable to do on admission. You'll get it back later. It might help you with stratification. Although I suppose you could argue if you have a 25-year-old that looks mildly ill, probably getting an IL-6 that could be that beneficial. Radiographic studies, we don't need to do x-rays on these patients every day. Remember, one of the concepts of this is to try to minimize exposure to healthcare personnel and others, and also to free up our x-ray, our radiology suites. We can't have people going getting x-rays every single day. Use clinical judgment in terms of how often you're going to get those radiographic studies. So how do we diagnose this? Again, it's based on epidemiology, which at this point is that it's around us. So you got to consider the exposure rate. Remember that this has started, because it's an evolving outbreak. It started with a fairly narrow case definition of being exposed to somebody from Wuhan, and now it's somebody from Kentucky has a potential exposure. But it's still reasonable to ask that question, because it's amazing when you talk to the epidemiologists at the health department, they're still able to track a large percentage of patients to a contact of a known case at some point when they really dig down. So if we dig down into that, we might be able to identify that, oh yeah, my neighbor actually was sick with something similar to COVID, and that gives you a heightened awareness. Examining and routine tests, really non-specific. CT scan, if you don't have a rapid test available, has some characteristic findings. I believe we'll get more information as time goes on. The specificity of the illness is variable in the reports, and over time we'll get more clarity on that. But it's still a reasonable diagnostic aid. And testing, of course, has been a major focus of efforts from all the hospital systems trying to increase access. We started with a fairly unavailable test in terms of getting it from the health department or the CDC, to having more and more labs go online on our institutions, so that we have a testing capability that will meet the needs of our healthcare workers and our patients. So I've listed a few of those laboratories over time as they've developed. And you note under the names like Diatherix and Roche and BioFire, Cepheid, that the Abbott test, for example, it's incredible. Now we have a test that potentially is available in 13 minutes to get the results. So point of care testing is probably evolving and will be available in our institutions, which will help us in terms of getting back to work, getting our patients placed, getting a better idea of the illness itself. We still are having an awareness of conservation of our supplies. So not we have, this is part of the story for this outbreak to date. Conservation of our supplies in terms of PPE, in terms of also our testing supplies, whether it's viral media, swabs. That's still an ongoing effort, and every facility has their different plan to try to maintain good supply to meet the needs that we have for testing our patients. So who do we test? Basically, at this point, we still have somewhat of a conservation mode approach that is focusing on hospitalized patients. That may change as our capabilities increase for testing, but we're focusing primarily on hospitalized patients to help us with transmission-based requirements and for diagnosis, and healthcare personnel who have had contact, as well as potentially the high-risk symptomatic outpatient high-risk group who are at risk for poor outcome. So we're trying to avoid testing the worried well, and anyone in the ED, when we're in a period of testing resource management, to send some of those patients home for home quarantine. But that will differ over time. As we increase our capability, I think we'll change some of those criteria. So what I'm talking to you about today on the 3rd of April may change, in a couple of weeks, because we believe within the month, we really should have a marked increase in our capacity to test. Looking at some of the virology again of what to expect when we're making that diagnosis, here's a representation from the American Journal of Respiratory and Critical Care that looks at patients and their symptoms, which is represented by the orange. The orange boxes are their symptoms. The blue dots are when they stop their symptoms, and their viral loads. So the first orange box represents the date of first viral detection. The last orange box indicates the date of negative, the last one, negative viral PCR. And so you can see, if you look at the blue dots, that some patients, as their symptoms resolved, their viral loads really tailed off, but there are some patients that still had detectable viral loads for a week or so afterwards, which, again, even if you can detect a viral load, we don't necessarily know that they're infectious. But that starts to help us formulate, again, when a patient is symptomatic and they're resolved with their symptoms, how infectious are they? And I think that the answer is, over time, as you resolve your infection, a week or two later, you're not likely to be as infectious, although some patients can still have excretion in other areas such as the stool. There's another, looking at a patient from Korea who, this is the day one of onset, where you can see there's a high viral load, and over time their viral load decreases into the second week. And you can see where their symptoms are. They had fever and chills and myalgia that first week, and then they start to have decreasing in their fevers, still have persistent cough, still have some mild loose stool, and but their viral kinetics are going down over time. The viral test kits are all fairly similar, although it depends on the technology and the platform that you're using, but it's obtaining a specimen with a swab, usually nasopharyngeal. Over time, that may change because we're going to get more data. Maybe there's going to be better sources for and accurate, but I think we're going to need more data. Right now, it's still nasopharyngeal, but over time that may change. Who are we CT scanning? We're still not CT scanning. We're certainly outpatients. We're not CT scanning most of them, because if you're well enough to be an outpatient, probably don't need to get that CAT scan. It just occupies a limited resource. And as we have more testing capability going online, I think we'll use CT scan slightly less. For hospitalized symptomatic patients, where we're still trying to make decisions about care or placement, CT scans might have some benefit. When we look at general treatment guidelines, similar concepts. We're trying to shorten length of stay for patients, considering discharge sooner than later, to try to have a good throughput of patients. Remember that if you're in the middle of a surge, you basically can't keep everybody in the hospital. Now, that's easier said than done, because in reality, when you're looking at places that have patients that get sick with this, especially if you're an older age group, they're sick. And even if they're better, it's not that easy to just transfer them to a nursing home or send them home, because they might have, if you're 80 years old and you have an 80-year-old husband or an 80-year-old wife, it might not be that easy to take care of those patients, especially if they don't have good family support. So that area is still it needs to be clarified. Of note, if you're thinking about transferring patients to other facilities like rehab and LTACs or nursing homes, figure out what your requirements are going to be beforehand. Anticipate that where your testing capability is. If you can get a PCR test on the same day, great. A lot of places like nursing homes will require you to have 2 negative tests 24 hours apart and be asymptomatic for a period of time. So you have to anticipate, for example, as a hospitalist, that you need to plan for that patient to get out of the hospital, and that you don't want to do it on the day of discharge. That will just delay discharge and potentially, again, increase the risk that something happens to that patient, and also takes up a bed that another patient may need. Choose your laboratories and medications with a mind to try to decrease healthcare exposure, healthcare risk to the healthcare provider, such as, if you could use a once-a-day antibiotic, use a once-a-day antibiotic instead of a 3 times or 4 times a day antibiotic. If you could switch to oral once a day, switch to oral. Same with all your other medications. You don't necessarily need to check a serum porcelain level on a patient every single day. You need to make judgments based on the clinical needs of the patient. Remember that in in the past, we've had the luxury to drain patients of all their blood, and then if they're really low, we can transfuse them. But in this outbreak, we also have a shortage of blood supply because it's an outbreak that has affected the availability of transfusion. So take all that into account in terms of once we're looking at our patients. Remember that other care suffers oftentimes in the midst of outbreaks. This isn't a new story. When you look at SARS, MERS, other outbreaks, when you look at the rates of outcomes for heart attacks, other illnesses that require acute care, oftentimes they can get affected and the outcomes can suffer. We're trying to pay attention that every patient that needs whatever acute care that they need, that we are attentive to that need and not getting sidetracked with COVID. It's not easy to do all the time because, again, mentally we're very preoccupied with something that is acute happening. It's in our institutions, and the longer this goes and the more cases you have, the more difficult it is to maintain concentration and focus. Watch again for PTSD. I think PTSD and stress anxiety, you can see it in the meetings that are occurring in our institutions because people are getting a little short with each other sometimes and short on the wards with each other. Everybody is trying to do the best they can with the information they have, with the resources they have. So we need to really pay attention to that before, because it is hard enough to do this work. Supportive care is still the primary focus. Oxygen is required in a high percentage of patients that are hospitalized, and ventilator use, especially with the high-risk patients. Antibiotic use is common, but I would caution you to try to limit antibiotic use to 5 days or later if needed, because the majority of these patients do not have bacterial infections. Although, depending upon what time of the year, you may have co-infections, such as influenza. When we look at ICU care, remember that still a significant percentage of patients will need ICU care. The older you are, the more likely you are to end up in the ICU, and the higher your case fatality rate. If you're looking at summary recommendations, there are a number of good articles, especially from the Surviving Sepsis campaign. And the overarching descriptions are that oftentimes you have to consider earlier than later intubation. Need safe airway treatment, especially if you're intubating with rapid sequence induction. Practice your protocols because, again, that is a high-risk procedure for aerosol generation. We got to protect ourselves with N95s. The Italian experience talked about a significant percentage of their patients needed to use the ICU, and it did strain the system. So there are models out there. There has to, and this is ongoing in all our institutions, the discussion of planning for surge and capacity, whatever that may be. Capacity related to your ICU beds, to your staffing, to your ventilators, addressing code status before patients code. And there's a movement to try to coordinate this statewide, at least community-wide, between the various institutions, which is a great step forward because not all of us will have at one point in time the same bed availability, and there's a movement to try to coordinate bed availability for our patients. Which brings us to some of the concepts of rationing of care, which is now also part of this outbreak. This has definitely strained resources, and in certain areas that have severe surges, they are outstripping their resources. And so you have and this is not new literature, it is literature that has been discussed before when in terms of disaster planning, whether it's hurricanes or in this case, a pandemic, principles that each system and hopefully statewide and community-wide come up with ways to ration care based on these principles of fairness and duty to care, consistency, accountability. And there are various algorithms to look at whether or not the patient requires ICU care based on those principles, based on stratification of SOFA scores and comorbidities, that the higher the SOFA score, the worse, the less likely you are to benefit from ICU care. So if you're really going to end up dying and you have a terminal illness already, that patient may not benefit, and you're still trying to save the most lives, save the most life years, do things in an ethical framework and try to eliminate the individual physician from making that decision. You're trying to have a system and a process in place that allows patients to be triaged without a one-off where the physician has to make that call. So treatment will change. This is treatment on 4.2. Treatment's going to change, and it changes every day. If you go back to the University of Washington or Mass General, the treatment recommendations have changed over time, and they'll continue to change. So we need to just keep on top of that because studies continue to be published. Now, I'm sure there's 10 studies published already today that may slightly change how we look at treating patients. But steroids generally are still not helpful to date in clinical. They're in clinical trials. They may prolong shedding. They've been looked at in previous outbreaks, including SARS. But they may have a role in a small segment of patients, and that's to be determined, especially in those that are undergoing cytokine storm. ACE and ARBs are not considered considered harmful at this point. There's been a debate in the literature, but in general, the American College of Cardiology has recommended to continue those agents. There are, in every treatment algorithm, including this, there are no approved FDA measures. There are no large randomized clinical trials. So if you try to stick to the standard of trying to have a large randomized clinical trial, we're not going to be there. You wouldn't treat anybody. And I think in this instance, we have to use common sense again, and what information do we have, and try to apply that to our patients. But still keeping in mind that we need to enroll patients in clinical trials because we need the data. And there are going to be more data available within the year. But under investigation and more frequently used are hydroxychloroquine, remdesivir, convalescent plasma, tocilizumab, and monoclonal antibodies. There are vaccines under development. If you look at different algorithms, this is just one algorithm because everybody has an algorithm. This is from the University of Washington. It's evaluate in their institution. They have more availability for remdesivir. We do not yet, although we have used it. It's still difficult to obtain, as Gilead had closed down some of their trials. But it basically is based on risk stratification. If they're sick, if they're mildly ill with no oxygen requirements, basically you probably can send them on their way. If they're ill and they start to require oxygen and develop signs of hypoxemia, then those are the patients that start to get shunted into treatment pathways, of which the first is probably hydroxychloroquine. Remember, the data are still sparse. Lopinavir, ritonavir has kind of fallen off a little bit in terms of its favor. There's only one small trial, however, that did not show mortality. If you look at the different medical centers, whether it's Mass General, UW, Michigan, Penn, et cetera, this is still way down on the list in terms of use. Hydroxychloroquine is still has trials that will be coming out, of which still has not dissuaded anybody from using hydroxychloroquine for the most part in patients that are more ill. So, and for today, that's probably the most common medication used, and indication will vary by institution, but essentially a patient that's at higher risk who has increased oxygen requirements probably would be treated with hydroxychloroquine. Remember, its major side effects in the treatment setting are QT interval prolongation, although you can have other more minor side effects, nausea and vomiting. And most of the toxicity, such as retinal toxicity, is a after long-standing use. The drug duration, most institutions are recommending 5 days. Some have said 10 days. The drug does have a super long half-life, 40 hours. So after you treat someone, it's probably going to be hanging around for quite a while. There are no data comparing shorter or longer treatment. Remdesivir is an investigational agent initially developed for Ebola. Still difficult to get in terms of compassionate use. We have used it. Whether or not it's had an impact, on our N of 1, I can't tell you. We're still treating that patient. But there are clinical trials that are available to try to involve your patients. Immune modulators, we have used in our patients here. They include tocilizumab, again, for patients that have cytokine storm. That's a small percentage of patients that really seem to tank, where they develop an ARDS and all of a sudden have persistently high fevers, cytopenias, organ dysfunction, and they're really looking like they're going down the tubes, we have used this agent. Whether or not how effective it is, difficult to say. Again, it's not clinically, there are clinical trials and we need to enroll patients in this. But in our patients that really seem to be dying, we have used it, and we're still waiting to see the impact. There's one small study reported out of China. It's not in a peer-reviewed journal at this point, 21 patients. But those patients, according to their reports, did have benefit in terms of clinical response, but also those patients were receiving steroids, Kaletra, which is lopinavir, ritonavir. So it's difficult to really understand the benefit. Convalescent serum, we have taken, and plasma, we have treated patients with this. 2 patients. There are data from previous outbreaks with a meta-analysis in the Journal of Infectious Disease in 2015, where it does show some benefit in terms of overall mortality. But when they're looking at all these studies, which there's over 30 studies, the studies are all done differently, so it's difficult to interpret the benefit. They would say that overall, maybe using it earlier than later is more beneficial, that maybe it does improve mortality, but ICU critical care support may not change that much. So we'll have to wait and see. The data from Wuhan is in 5 patients, of which there was seemed to be some beneficial effect, but again, it's 5 patients, and the effect was reported at about 12 days. The average duration of hospital stay for these patients in Wuhan, for the ones that improved, was long though still. These patients were in the hospital with a length of stay of over 55 days. So more to come on convalescent plasma data. There is you need evidence of antibody titers. There is a FDA emergency IND that is in place at a Baptist hospital. It's being put in place at St. Joe's Hospital System. And it is not a straightforward, it's not just, it requires coordination of your blood bank, your hematology oncology personnel. It does, at this point, we don't have readily available neutralizing antibody test because that's part of the IND. But in terms of clinical, potential donors, we're talking about our patients that have resolved their illness. They're asymptomatic for 14 days and they test PCR negative. So how to arrange that in your particular systems is something that you have to go forward with. You can contact Baptist to figure out some of the ways that they went about that, but it requires a coordinated effort. And that's part of the issue of this outbreak, which is it's not ready-made. That we all went through medical school and did training to take care of individual patients. We're really not that focused on population health and how to coordinate different factors, but that's really what this requires. It requires coordination between public health, where they can give us line listings of patients, and the blood bank and our different subspecialties to try to coordinate and deliver care to our patients. It's not just one simple thing where I can look up in a reference and just give one patient a treatment. This is trying to organize treatment for groups of patients which will require more coordination. So that's something that all of us can, and it's not something that can happen in one day. It really does require some time also to smooth out the process. Minimize your, now this is John Barton. This is John Barton. And John Barton says, this is what John Barton says. So he gives me the update. He can't be here today. So what he said last week was basically to focus on minimizing time for your patients in the hospital. If you're talking about OBGYN, utilizing C-sections, discharging if it's stable, don't sit on premature rupture of membranes, and review your elective procedures. Don't encourage active pushing in the second phase of labor. Now, what about today? Today, he said, I want 2 more points to be emphasized, and that is, do not delay cord clamping after delivery of babies. You potentially have increased risk of transmission to baby. Now, this is also going to be under evolution because there's still a lot not known. We're saying, on one hand, there's not a lot of evidence of vertical transmission, but on the other hand, there's, in terms of a risk-benefit analysis, it's still okay to clamp that cord earlier not risk the potential of transfusion of an infection to the baby. And then if the baby is, if you have a stillborn situation, to treat the placenta as infected tissue and just use that, and you just use good infection control measures for that aspect. So again, we have no effective treatments, nothing FDA approved. And what measures can we apply? Where you're still applying public health measures. That's isolating, identifying, isolating, and treating when we're talking about our systems. So we're identifying our patients, we're screening them, we're screening our staff now, we're anybody that comes into the hospital, we're trying to funnel patients into a single entrance, including staff as well, testing them to make sure they're not sick, increasing our risk of exposure to each other and to patients. We're focusing on emphasizing patient portals, trying to get them to use telemedicine, other ways to interact with us rather than coming in person. We're isolating our potential patients, protecting healthcare personnel and patients, talking about PPE, using N95s, face shields, goggles, looking at the face shield, something like this in terms of technology to try to decrease our chances of infection, especially of eye surfaces, potentially more beneficial than just using goggles. But if you're looking for a large randomized clinical trial, there's none that's been done. Engineering controls, working on maintaining negative pressure rooms as best as we can, converting wings of the hospital. Administrative controls, which you've seen, limiting visitors and movement. Here's some of the, for facilities that are starting to increase in the number of cases, they're going to start to run out of negative pressure rooms and potentially N95. So there are some thoughts around how to manage that, because at Baptist, we have not reached capacity. We have negative pressure rooms. Facilities and other places may not, and may run out of N95s. So basically the teaching, and this is a compilation of what WHO would say and what CDC says, is triaging on the basis of risk and aerosol producing procedures. So the teaching point for aerosol producing procedures is that not all things that you might think about produce aerosols, such as high flow non-invasive ventilation in terms of BiPAP, CPAP, when we're giving nebulized treatments because handheld MDIs are not available, trying to use appropriate protection. If that's the case, you're trying to keep those patients in airborne precautions using an N95 face shield. If you're critically ill, basically we're putting those patients into airborne and N95. Those are patients on ventilators or shock. They're going to require a lot of invasive procedures, and it seems if we're triaging, those are the patients we're focusing on. A hot topic to try to sort out, which is still controversial, that all places are not, have not completely figured out. And you also, if you look for the data on how these precautions are generated, it's harder to find. But in general, most of our hospitalized patients, if we're trying to get them out of isolation or to high-risk areas like a long-term or assisted living facility, are going to have to be asymptomatic and have 2 negative PCR tests. So in terms of thinking about that, if you're the hospitalist, you got to plan for that. This will be easier to obtain the more we increase the capacity for testing. There is a non-test based strategy that is on CDC's website. But really, if you're sick, I think the standard is to focus on a test-based strategy. Every facility is going to be set up slightly differently. In our facility, in the facilities that we have here, we are trying to also have a multidisciplinary group of people, including the intensivists, the infectious disease physicians, the infection control people, the hospitalists, trying to look at on a case-by-case basis to figure out some of the tricky areas. They don't always fit into a category, and you have to use clinical judgment. So there are ways to see our patients without physically entering. That's a concept we're trying to decrease our exposure. And this is one example of, but it's probably not going to be the example. The example is probably going to be a cell phone or an iPad. And I would plan sooner than later because basically, if it's the same story for everything else, as somebody latches onto that concept, it's not available. So you try to get those, like masks or PPE or cell phones. As everybody latches onto that, difficult to fill those requests. So anticipate that and start working on supply. We are still doing surge protection and projections, projecting an outbreak time course. For Kentucky, it's still probably into May. Looking at our equipment, constantly keeping track of inventory, our personnel strategies, constantly communicating. It's encouraging to have the communication increasing between systems and not just single facilities to make this work. How do we prevent the spread in hospitals? We have had some changes, so you might be confused about what's going on. And again, it's not unusual because we get more information as time goes on. At the very beginning, nobody's going to have this on their radar, but as time goes on and we see, for example, that healthcare workers are part of this getting infected, we start to try to mitigate that to protect ourselves, to protect our patients, and come up with those strategies. Also balancing that against resource availability. So identifying risk factors in clinical presentations. Remember, if you're a clinician accepting a patient from the outside and potentially you bypassed the controls that are in place at your facility, you could potentially have a STEMI that has COVID. So if you're at a smaller facility and there's not a funnel to try to evaluate closely those patients, that's on you. You've got to figure out a way to really risk stratify those patients as they come into the hospital. Follow infection control guidelines. Now, it's not always, it's self-evident, but if you look at previous outbreaks, if you use infection control measures, you will protect yourself. 100%, even though healthcare workers are involved in this outbreak, 100% are not infected. The majority are not infected. And that's if you use infection control measures, that all transmission-based precautions. You won't get infected. The majority. If you don't, you will. And that's clear. If you didn't use PPE in the Italian outbreak, all those physicians that got sick. If you don't recognize that potentially you're dealing with an infected person, your chances of getting sick are increased. But there are anecdotal evidence, simple things like, what's the effect of a mask? If you look at a patient that was infected in China, published in one of the journals, this patient had 3 car trips on their way to getting to a certain place in China. First 2 car trips, he was symptomatic and he was a positive case for COVID. Did not wear a mask. Those patients in the car, during the car ride, they got ill. The third group of patients that he, potential contacts that he drove in the car with, he wore a mask the 3rd time. None of those people got ill. So it was a good example that wearing the mask actually could prevent transmission. And that's part of the message. So we're isolating, we're using these face shields, we're using standard operating procedure, hand hygiene. Remember, hand hygiene, it's not 2 seconds, it's trying to do 20 seconds. This virus does get killed with soap and water, so that can work. And we're trying to cohort patients and follow transmission-based guidelines. And we have changed to a universal mask policy. So that is confusing to some people. Why wasn't that done before? Well, we don't have all the information at the very beginning of this outbreak. And as time goes on, we get more information that healthcare workers are involved. So we're trying to prevent transmission to each other and to our patients by wearing a mask and maintaining that social distancing. Here's so hand washing does work, but again, it works depending upon if you do what we probably previous to this outbreak, we did the 2-second hand wash. We're supposed to do the 20-second hand wash. Now, a lot of people have asked me this question: Does SARS infect PPE? What data are there? So there are tiny studies, hard to know what to make of it, but they're published. So you could point to this, and I ask you to be careful evaluating this kind of literature. So one study evaluated PPE sampling of healthcare workers on 15 confirmed patients. And they basically, the bottom line is they did not find contaminated PPE. But of note, healthcare workers only spent 6 minutes in each room. That's the median time. And not all the patients were symptomatic. So some of them were asymptomatic, so potentially not as infectious. And all patients were in negative pressure rooms. So you're going to take that with a grain of salt, but some of that also says it's not like you walk into a room for 6 minutes and all of a sudden you're covered. So that's good to know. Here's another infection control issue in terms of if you don't clean the rooms, and you went into the rooms of 3 symptomatic patients, this was in Singapore. Prior to cleaning, you found COVID all over the place. You found it on the table, the bed rail, the chair, the light switches, the stethoscope, the sink, windows, air outlet fan, toilet bowl. So it was all over there. Now, interestingly, the anteroom floor was negative. They studied samples, only 2. So this is not huge. These are small studies, but they give us a little insight maybe. And they studied the gown, the face visor, and the N95. They could not detect the virus, although they did detect it in the tip of a shoe. But interestingly enough, they did not detect it in the anteroom. So it's not like you had it on the tip of your shoe, then you spread it all over the anteroom. Well, that's good to know. So you might feel comfortable, but I got to put this in there, which is a little different. Okay, what happens in this is not COVID, but this is just if you worked on a respiratory virus ward, and you're a healthcare worker. They studied 148 healthcare workers for a shift. So if you wore your mask for a shift greater than 6 hours, 10% of those masks were positive for viruses from that ward. So what does that mean? It means if you continue to wear your mask a long time, you got to treat it as a potential fomite. And that's important because when we're using masks every day in the hospital now, we still have to be careful about the way we use hand hygiene, the way we take our masks off and on, the way we use our masks. For example, when you walk the wards and everybody's got a mask down here, or they got it on the top of their head, or they're eating food and then they're putting their mask on and they're doing all this, that's a potential for a problem later on. So we have to treat it as a potential fomite. So you're not out of the woods. You got to be careful about that. When we look at previous outbreaks related to these types of coronaviruses, there are healthcare associated infections. So if you review the factors, these are some of the factors that are involved when healthcare workers get infected. Lack of isolation in negative pressure rooms, suboptimal adherence to infection control measures, patient flow, a non-recognition of aerosol procedures leading to healthcare workers getting sick, and visitors. So we're trying to deal with some of these things, mitigating those factors in our own facilities. Visitor restriction, paying attention to aerosol generating procedures, limiting patient flow. We don't want patients all over the hospital that are infected, and trying to minimize healthcare worker contact with those patients. This is that slide from Korea that looked at factors involved with suboptimal adherence to PPE. And just looking at the slide makes your head swim because there are many, many factors. But one of the things that I would recommend, again, is that red portion at the right-hand slide. We still are, if you're not in the middle of a surge and you're getting swamped, this is the time to focus on education, getting spotters out there, working on your protocols, getting people used to using PPE appropriately, because we have the time right now. We don't want to do that in the middle of when we're swamped and then we basically panic, but we have ingrained procedures, ingrained behaviors that will help protect us and help our patients. So we have learned something about the healthcare worker in COVID. We can use previous outbreaks to focus on enhanced vigilance. So if you look at Ebola, for example, workers became ill for simple things. Now, Ebola is a slightly different virus, really infected body fluids were the main focus. But the point of the matter is that still some of the behaviors that we do, simple things, touching our eyes, using our cell phone, not really paying attention to those infection control measures, led to you getting sick. We are increasing our supply of PPE. We're increasing our experience, especially now when we have time. And we're remembering that mildly symptomatic and asymptomatic persons can still spread the virus. Now, that's a message for us in and out of the hospital. So in the hospital, if I have a known COVID patient, I'm going to be so careful and use perfect PPE adherence. But then if I get out of here and just go hog wild in the community, especially when the cases are increasing, that's a great opportunity for me to get sick. It doesn't matter if you're a healthcare worker or somebody else. You got to pay attention to that type of stuff. Clinics got to still pay attention. Identify your patients before they come to clinic. We don't want to be infecting your office clinic staff. Try to transition to telehealth. There really has been a good movement toward using telehealth in our offices and clinics for a lot of the practices. That's been a great boon, and that'll probably continue to improve. If you do have a sick patient, put a mask on them. The mask will decrease some of their transmission, and put them in a room. And then if you have questions, you got to call your public health department. This is still important in terms of events matter, and we're still going to have to focus on some of those events. This is the parade on September 28th, and then 3 days later, we're filling up beds in Philadelphia. This is a little bit, now, last time I showed this slide, Kentucky got a B. So what changed? Now they got a D. And this is using cell phone data to map GPS travel. So before and after the outbreak. So currently, as of April 1st, we're doing less social distancing. And why is that? Probably because the weather is better and people get a little more complacent. They don't have the story of New Orleans. It's happening in New Orleans. It's not happening here. Or it's happening in New York. It's not happening here. No. Remember that it can still happen. If you look at Singapore, when they relaxed some of their social distancing, they all of a sudden were surprised. They went from 100 cases to 1,000 cases. And it doesn't take long. It is a fire. And we got to try to tamp the fire down as we build capacity, build capability for vaccine treatment and medical treatment. So right now, this is, we got to get that message out that we still, if you drive around UK's campus, nice weather, everybody's getting together. It's like it's a party. I've got teenage kids and college age kids. Hard to get that message through to them because, they're invincible, but they're also important to propagating the outbreak. We still got to flatten this curve. We still got to pay attention to that. This is from data in Seattle. If you have questions, there are people to get used to calling. Got to call if you're in the Baptist system. You call these numbers in terms of contacts to ask your questions. There's always questions. And your health department, try to get used to utilizing them as a resource. Really need to have better, especially for this. Again, we're not using the health department daily prior to this outbreak because, again, we're treating single patients oftentimes using our medications. But this is a different situation. We really need communication with the health department and the individual hospital systems because they have information that does impact how we do things. And it will impact our patients and our healthcare workers. This is the information from St. Joe's. And with that, we'll open it up to questions. Mark, you had some comments.
This is Dr. Doherty again. Just showing you our face shields that we just got in, or an example of the type of face shields that we got in. Can everyone see me? Okay. This is a subject that we're going to bring up next week. Dr. Holly Hall is going to help me with this. We're going to discuss the use of face shields, the appropriate use of face shields, what situations we're using them in, and also conservation of personal protective equipment and telemedicine in our own hospitals to help conserve on PPE. I'm Mark Doherty, the hospital epidemiologist here at Baptist Lexington. This is Dr. Rodrigue up here who's been giving our talk. Thank you, Dan, for that unbelievably thorough and detailed talk. We're both members of Lexington Infectious Disease Consultants, an 11-physician infectious disease group here in Lexington. I want to thank the Baptist system and the St. Joe's system for helping make this talk possible. This is part of LIDC's response to the epidemic. We're in the relatively luxurious situation right now where we have gotten experience taking care of some of these patients, but haven't been overwhelmed like some other places. So we've been able to take the time to learn and to try to educate everyone. Next week, Dr. Holly Hall of our hospital service is going to help us in preparing some videos that you guys can watch on PPE conservation, telehealth in our own hospital. I do have an assignment for everyone for next that I'd like you to watch. It's controversies in hospital infection prevention, and it's just a brief video and talk from Mike Edmond at the University of Iowa about the face shield strategy
to reduce COVID-19 nosocomial transmission. It's an excellent little piece there that won't take very long to look at. So thank you. I think we'll open it up for questions.
Now, there are a couple of questions. So first question was, how plausible are the recent reports of airborne transmission? So there was a study published that got some notoriety from MIT that discussed the dynamics of a cough. And this is the physics of cough. And I guess you have to be a specialist in the physics of coughing and particle distribution. One of the points of the article were that potentially we need to change the social distancing from 6 feet, because with an extremely forceful directed cough, you could generate a particle up to 27 feet. That got some notoriety and also somewhat of a rebuke from Dr. Fauci, because that doesn't really represent typical dynamics of coughing. I'm not an expert on particle dynamics of coughing. I think we know that it can be aerosol transmitted with high-risk procedures. In terms of the spread right now, it doesn't appear as if aerosol transmission is supported based on some of the factors. For example, masks do protect patients and do seem to decrease transmission from routine coughing by capturing those droplets that you're expectorating. And when you expectorate, if you had a forceful enough expectoration, potentially you're going to have leakage of aerosol particles around your mask. That's the major difference between an N95, which filters 95% of the particulates, versus a surgical mask. Again, an N95 works because it has to, one, it's got to be fitted so that you have an airtight contact with your face, and a mask is not. So you have other ways to have particles escape. So based on the dynamics and the reports, they still think respiratory droplets are the most important route, as well as fomites. But aerosol is always a potential, especially with paying attention to the types of procedures. Mark, do you have a comment on that?
No, I think that was very thorough. I think we've almost gone on for an hour and a half now. This was originally set up as a webinar with questions back and forth, but this whole situation is so complex, so fluid, so dynamic, so many issues with shortages of PPE, conservation of PPE, testing issues, transmission issues, treatment issues, therapy issues, that I think we're just going to have to hold off on a lot more questions.
Let me answer one more question here, and that, because it's important for all those out there, that is, when can a person donate plasma? I think plasma is going to be a reasonable treatment, especially at this time for our more ill patients. There are criteria, and that is, we want somebody that is not ill for 14 days and tests negative by PCR. So everybody that gets discharged will be asked at some point at the time of discharge to consider being a donor. That is probably a public service for all of us to try to contribute to helping our patients. It will potentially help them get off ventilators sooner and get out of the hospital sooner. And as this progresses, there'll be more efforts made toward publicizing that to the community and mobilizing that as a treatment source. I think that'll do it for now.
Okay, thank you all. Stay safe.
Thank you.
Well, we're going to talk next week, planning to talk at the same time. We'll discuss some of the PPE issues. Maybe we can give an update on the convalescent plasma therapy. And then we will have Dr. John Barton here to discuss his OB national guidelines. Thank you.